known as the gas of life. And that might be a little backwards from what you guys are thinking as far as, well, oxygen is really the gas of life. But oxygen, if it's not hitting the tissues and doing what it's supposed to do and combining with glucose, then we can't have CO2. We know that if they're producing CO2, they are metabolizing, and that is what we're actually looking for and happy to see. All right, I'm going to spend a little bit of time here talking about semi-quantitative capnometry. I promise you that everybody that is in W-Dayton, and what I actually want to kind of point out, and again, not picking on anybody in particular, is how does this thing work? So the way that this works, and I've always kind of said this, and it's true, but not really, so I am actually going to clear that up today just to kind of tell you guys exactly how it actually works. Previously, I've always just mentioned that the paper inside of your colorimetric device is a piece of litmus paper that reacts to hydrogen ions. Hydrogen ions are very acidic. So when the patient exhales, if there's hydrogen ions attached to that exhalation, it will cause that litmus paper to change colors. That's kind of how it works, but not really. So the real thing that actually is going on here is with this colorimetric device, there is a piece of paper in there, which is actually just a filter. And that filter is impregnated with a chemical that will react to acid. So if an acid hits that, then we know that it's going to end up making it change color. So the filter paper is infused with a pH sensitive chemical indicator that responds to acidic hydrogen ions, and that is during the exhalation. So this results from a couple of things, and I'm not going to get into a chemistry lesson, but I do want to show you this. It results from CO2 and H2O forming H2CO3. So what H2CO3 is carbonic acid. I'm actually going to break this down here for just one second. If I'm looking at H2CO3, we know that CO2 is carbon dioxide, di meaning two, okay? Carbon monoxide, mono is one. So carbon monoxide is one, CO, and there's no two with it. Carbon dioxide is CO2. And oftentimes that is actually miscommunicated when we're going out for carbon monoxide alarms. I hear people, dispatchers, and I hear firefighters alike, oftentimes will get on the radio and say, respond for a CO2 alarm, or dispatch, there's no CO2 readings in the house. So CO2 is carbon dioxide. We know that H2O is water, and this becomes important. So when we put those two things together, it becomes something called carbonic acid. And we get rid of carbonic acid in one of two ways. We either urinate it off or we breathe it off. So if I look at this H2CO3, I know that water is H2O. And I just put a little hash above H2 and the O. Well, that gives me a couple of other things that are left there. I've used H2O, so I've used one of these O's, which leaves me now with an O2. And then I have not used the C, so CO2. And you can see that how when those combine, it forms carbonic acid. So the way that they combine, they can break down as well. One is going to be breathed off through exhalation, and the other one is going to be urinated off in the form of water. So that is all that carbonic acid is. So when you're using this, you're going to note a change to the paper. And I asked this question yesterday. I said, so if I put this device on, how do I know if it is effective? And the answer overwhelmingly was color change. And I think that's probably what you guys would agree to as well. And that is true. So I put the device on, I squeeze the bag, and I get color change. Well, what does that color change actually indicate? And we need to be familiar with that if we're going to use this device. So we get color change, and most people, and I hear people all the time, these little mnemonics, which are great, but Barney's bad, Big Bird is good. So if you see Big Bird yellow, you know that is good. Barney being purple, if it stays purple, that is not necessarily a good thing, because we know that we're not capturing end-tidal CO2. So we put the cap on, but then what? So these are actually the numbers, and this is directly from the manufacturer. And I'll bet unless somebody has actually taken the time to either A, teach this in a class to you, or you've taken the time to read the package insert, most of us, me included, I'll be honest with you, most of us have probably not taken the time to actually look at this. Now, I did years ago because I started teaching capnography and I wanted to be educated on the colorimetric device. But had it not been for that, I probably would still be using this thing today inappropriately. So if we look here, the A, B, and C, and I just circled the B so that you can kind of see what I'm looking at here. I've got A, B, and then C. So A is over here in this purple I'll call it dark tan category. And you can see that the numbers, let me show you where I'm at. Those numbers in the A category reflect 0.03 to less than 0.5%. Well, what does that mean? So if I put this on and it stayed this color right here, what would that tell me? It would tell me that the patient has a reading of somewhere between 0.03 and less than 0.5. But what you guys need to know is that equates to this number, the less than 4, and that is ETCO2, end-tidal CO2. So purple, not good, because we know that they have an end-tidal CO2 reading of less than 4. If we look at the B area, that is going to give us a reading of 0.5% to less than 2. And that translates to 4 to 15 millimeters of mercury of end-tidal CO2. And then the C category is going to be 2 to 5, and that translates to 15 to 38%. So here's where I'm going to challenge you guys a little bit. Everybody yesterday, me included, and I think you guys would agree, would say that if I put this on and I get a color change, then I know I'm good. Well, that might be true. If it's purple and it goes to yellow, and you have that yellow color change, we're in that range, and let's just call it a 3.5 or a 4 up to a 5. Look at what your end-tidal CO2 reading is though. It's 15 to 38. And I want you now to think about what a normal end-tidal CO2 reading is. What the range that we should be shooting for, and this is from birth all the way through life, okay? So there's no differences in neonates versus peds versus adults or geriatrics, is 35 to 45. Well, this is only hitting the low end of that normal range. So if you have somebody that has an end-tidal CO2 reading of 45, it may not work as accurately. If you have somebody that has a lower end-tidal CO2, it may be difficult because we're simply looking at a color change. Does that make sense? I want to make sure that I give time to ask questions for anybody that has them. Let me clear that. Sorry about that. All right, one other thing on this particular slide that I want to point out to you. At the bottom graph there, it has adult over 15 kilos and pediatrics less than 15 kilos. So the concept here is this, and this is actually known and it's been relatively studied to where we know this information to be true. The cap, we all know that this hooks to a bag valve device and then goes to the end of an endotracheal tube. That connection is 15 millimeters on both caps. So if I have a pediatric patient that is intubated, their tube is a 15 millimeter adapter. Same concept in the adult patient. So situation, you have a pediatric arrest, unfortunately, you try to find in your bag your pediatric colorimetric device and you're unable to find it. So what do? We grab the adult. Don't do that, okay? And there's reasons that we don't want to do that and why these things are made in different sizes. Here's what happens. If I put this adult cap on a pediatric tube, when I ventilate my child, the first breath, oxygen goes through, it goes into the patient. I have good rise and fall of the chest. I know that I'm doing good. When the patient exhales, that breath comes back, and we know that they are exhaling carbon dioxide. Well, because the cap is so big in proportion to what their tidal volume is, they're not able to completely clear that breath. So as I follow up and squeeze that bag a second time, I'm actually forcing that carbon dioxide back down into your patient. So in pediatrics, if you do not have the right size cap, I would rather you listen to lung sounds, look for condensation in the tube, direct visualization through the vocal cords. Always go back to those backup mechanisms. Don't use the wrong size cap because it will make your child hypercarbic, which is a high level of CO2 in the blood, and that is going to end up causing other problems downstream. So I wanted to point that out. Who can we use it on? Different patients, and it depends on how you want to approach this, but definitely intubated patients. That's really a no-brainer. And I just told you that we did the updates for the 2020 American Heart Association guidelines, class 1 recommendation. If you have capnography, you need to be using it. It's a class 1 recommendation, which means that not only is it beneficial, they know that there's not going to be any harm that goes along with it. Chief, Carl, am I good on your end? Chief Atkins is saying that I am frozen up.
I still see who can we use it on.
I'm sorry? Okay. All right. Ellesmere, I'm assuming you guys are still here as well. It must be on their end, so.
Yeah, Adam, we're good on this end.
Okay. Sorry. Thanks, Chief. I just texted Chief Atkins and told him that everyone else is still there, so it's got to be on their end. All right. So who else can we use it on? The non-intubated patient applications. So bronchospasms, your patients that have asthma, COPD, and anaphylaxis. Remember that those are issues with getting air out, not getting air in. So bronchospasms, if you have a patient that is a known COPD patient or asthma patient, you can certainly put this on them, and you will be able to tell if that patient is having any type of bronchoconstriction, oftentimes before the patient will even know that. So they may tell you that they're having a little bit of difficulty breathing, and you can see that they actually have a fairly obstructed waveform pattern. Go ahead and start treating that patient based on your protocol and on what your findings are. Hypoventilation, so if they're on drugs of any type, stroke, congestive heart failure, postictal patients, and then those with shock and circulatory compromise. But again, if there's one patient group that you guys are going to use it on, make that your intubated patients, and that's from a legal standpoint. Does a couple of different things: verification of ET tube placement, surveillance during transport. So we know, every time that you move that patient, we should be reevaluating where that endotracheal tube is at. So you intubate them in the house, you move them to the cot, you move them to the ambulance, you move them to the emergency department. We should be surveilling that endotracheal tube every time we move that patient. And I actually we didn't have CO2, end-tidal CO2, but back in my flying days at UK, I intubated a patient, took him into the trauma center, and as we moved that patient over, the patient started to desat. And they listened, and the tube was misplaced. And we were confident that the tube was accurately placed, and we had verified it a couple of different times. So furthermore, after they kind of looked into it, the guy actually had a lacerated trachea. So when they rolled him on a side to do a rectal exam, the endotracheal tube basically just fell out. So it was not our fault. But again, make sure that you are protecting that tube, because it's going to be your word against someone else's. Controlling ventilations during CHF and increased intracranial pressure, and then CPR. And this is a big one. It's going to tell you compression efficacy. So if we're not getting waveforms on capnography of 10 or above, you really need to switch out who who is doing CPR for that patient. It will give you early signs of ROSC, and we'll look at that. So if the patient gets return of spontaneous circulation, we're going to know that pretty quickly. And then it's a survival predictor as well. I said yesterday that I really thought that this information was going to come out in the 2020 guidelines, but it did not. that if initial end-tidal CO2 was less than 10, we know that it is going to be a futile attempt. So I thought that we were not going to even initiate resuscitative efforts. That did not come out. I want to be clear on that. So you guys need to continue to just follow your protocol as it is written. But we know that, you know, if you get there, you intubate them, you put them on capnography, and they've got an initial end-tidal of 4 or 5 or something like that, that patient is probably not going to do very well. All right, so capnogram, when we look at the capnogram, this is the waveform, and this is kind of the meat and potatoes of what we're looking at today. And it's divided into 4 different phases, and we'll look at each 4 of these individually. So phase 1 is the respiratory baseline. If you're gonna equate this to an EKG, think of it as the isoelectric line, right? The base or the bottom line, it's flat. So it is flat when there is no CO2 present, and it corresponds to the late phase of inspiration or inhalation and the early part of expiration or exhalation. So what I want to kind of point out to you is this. Remember that this is measuring exhaled carbon dioxide. So as as you think about that, and as you look at this waveform, it kind of seems like it should be reversed. As I am blowing out under normal conditions, you guys do your fire department physical and you have to do your pulmonary function test, right? As I start to blow out, what happens to the waveform? It starts to increase. Well, that's looking at oxygen and pressure. This is measuring CO2 only. So as I start to breathe out is when the patient or when the machine is actually going to start measuring that exhaled CO2. If I am breathing in or breath holding, you're not going to have anything at all on your waveform. So inhalation, as you can see down here, is phase 1, and that is going to be respiratory baseline. As the patient starts to exhale, this is phase 2, and this is called the respiratory upstroke. It represents exhalation of a mixture of that dead space. Remember, we have 150 cc's of dead space, and then the gas from down into the alveoli. And this makes sense if you kind of think about it. As I initially start to exhale, where is that gas coming from? And the answer is my mouth, okay? That's the first gas that starts to come out. That is going to be a very, very watered down CO2 because it hasn't been used for metabolism. So as you can see, as I initially start to exhale, my CO2 level is not going to be all that high. But as I continue to exhale, it becomes more and more concentrated, which is why the waveform increases and eventually starts to plateau. Phase 3 is that plateau. So it reflects the airflow through the uniformly ventilated alveoli. So not the dead space. Now we're down into the tissue where the gas actually worked. And it's starting to say, okay, this is actually a pretty good number because it's constant. So it's a nearly constant CO2 level. And then the highest level of that plateau is called the end-tidal CO2. And I want to make sure that I mark that so that you guys can see exactly what I'm talking about. That's right here, okay? This junction. That is the highest portion. You can see that that continues to increase, increase, increase over there to that very far right. And when it gets there, that is the most concentrated CO2, and that is going to reflect your end-tidal CO2. So when you're looking at your monitor and it says 40, for instance, that 40 or whatever that number is coming from that juncture. After we have exhalation, what are we going to have? We're going to have inhalation. So phase 4 is the inspiratory phase. As soon as I'm finished exhaling, the patient is going to take a deep breath, and then you're going to have that sudden downstroke or drop off back down to the respiratory baseline. Remember, we're not looking at oxygen, we're looking at CO2. And because of that, that is going to drop off very, very rapidly. Those are the 4 phases of your capnogram, and I want to look at some of these kind of in real time. So normal waveform, square box waveform. So something to keep in mind here, if you do an intubation and you have a tube through the glottic opening, you put them on capnography, and you have any variation of a square on your capnogram or on your capnography, you know that that tube is through the glottis. It has to be in the appropriate spot. If this is in the belly, you're not going to get a waveform. So esophageal intubations, you're not going to be able to see anything. So a normal waveform, this is what it should look like. My end tidal CO2 is 35 to 45. Here are the numbers here, 0 all the way up to 50. So if I drew a straight line over here, it would be somewhere in the 40s, right? I've got an end tidal CO2 of 42. We know that that is said to be normal range. So our treatment here would just be to simply monitor the patient. That's all we would have to do. Normal waveform, sorry, let me back up. Hopefully this doesn't throw anybody off again or freeze up. So we're looking at this, I simulate here, this is a normal waveform. We can look and see that our number is 41. So we know that that is an appropriate waveform, and we also know that the patient has a waveform that is within normal limits. So that would be good. Condition where we have a dislodged ET tube or we lose the ET tube, we're going to get a loss of waveform, and we're going to get a loss of end tidal CO2 reading. So what's our management? It's going to be, think DOPE mnemonic. So if you guys have been through different airway courses or whatever, DOPE is dislodged, obstruction, pneumothorax, or equipment malfunction. It's DOPE, and that will help you figure out what is wrong no matter what your endotracheal or your airway issue is. It's either going to fall into one of those 4 categories. So here's what's going to happen in this situation. Either one of 2 things. The tube came out, or the person that's supposed to be ventilating your patient is not squeezing the bag. Either way, we need to address that. So you guys can see here that I have a good waveform. It's a square. It's more of like a rectangle, but you get the point. It should have some kind of square waveform. If we draw a straight line over, we can see that our end tidal CO2 would probably be around 40. And then all of a sudden, I don't have that waveform anymore. I have lost it. You guys have got to evaluate that immediately. So, and this is anybody, you know, I know there's probably EMTs in the room, and this is for EMTs. It doesn't take a paramedic or anybody else to have to read this waveform. If you see that all of a sudden becomes flat, make sure that you're monitoring that and trying to fix whatever your issue is. All right, so in esophageal intubation, same concept. I put the tube in, I put it accidentally, it goes into the esophagus and not through the glottic opening. So I have an esophageal intubation. My partner squeezes the bag and they release. They squeeze the bag and they release, and I don't have any type of square waveform. I know that that tube is not appropriately placed. What I would recommend, quit squeezing the bag, extubate them, and then try to re-intubate them, okay? Don't think you have to trust your machine. And we used to always say, like, treat your patient, not the monitor. With capnography, that's one kind of variation from that. If you have a monitor telling you waveform capnography saying that this patient does not have a tube in, you need to believe that. So you're going to have an absence of a waveform, absence of end tidal CO2, or again, there's other things. Maybe you have your partner that's supposed to be ventilating and they're not ventilating the patient. If that was the case, though, it would give you a square waveform if the patient was in fact intubated. So the ultimate goal here is pull the tube and then re-intubate. Remember that we should never, ever, ever take a patient into the emergency department with an esophageal intubation. There's too many tools out there to recognize that now, and we need to be good at doing that. All right, CPR. So I don't know, again, from an equipment perspective, we use, and I'm not here to promote any products or anything like that, but we use the Physio Control Lucas device, which is now through Stryker. Our folks love it, okay? So we take the Lucas device, we put it on patients, and I asked yesterday, I said, what do you think those numbers are? And I already had a number in mind. In cardiac arrest, our folks feel that that number under CPR with a Lucas device applied is somewhere around 20 to 25 of end tidal CO2, and that's pretty close to probably what we're normally seeing. If it is less than 10, you got to stop and have somebody change out. Whoever is doing your manual compressions, they are getting tired. So we need to be able to switch people out. And this is why it's built into the American Heart, saying every 2 minutes we need to change out whoever is doing the chest compression. So if we have CPR, our patient is intubated, we're going to have square box waveform, so we know our tube is in. You're probably going to be somewhere in the range of 10 to 15, maybe higher with adequate CPR, and that's why we're getting 20 to 25. And then the management there is if it drops below 10, then we need to back up and figure out what we're going to do to get this person appropriate compressions. If any of you guys, Ellesmere, if you guys have a Lucas or another Azole auto pulse or anything like that, and you want to tell me what your numbers are, feel free. And you may not have that device available to you, I'm not sure. All right, so obstructive airway. Another thing that we can pick up on with using capnography is a patient that has an obstructed airway. So the other thing that people will say is they call it a shark fin waveform. So if you look over here to what the waveform looks like, you can appreciate that it kind of looks like a shark fin. And this makes sense. So any of the obstructive patterns, asthma, emphysema, COPD, those are issues getting air out. It is not an inhalation problem. It is an exhalation problem. So if we're looking at this waveform from left to right, we know that that is time, just like an EKG is. As the paper moves across to the left, that is time. Same thing in the end-tidal CO2. So if I am starting to exhale, but it takes me longer to do that because I have an obstructive problem, it is going to tilt back that waveform and give it a shark fin appearance. So this is legit. You guys can put patients on the monitor on end-tidal CO2 and actually pick up on this before the patient ever even realizes that they are having a difficulty breathing or an obstructive issue. So you put them on, you see that shark fin pattern. Again, follow your protocol, but start thinking about, okay, what am I going to do for this patient? What is their ailment or their diagnosis? And what do I need to do to try to help reverse that? If they are having difficulty breathing, you know, you hear wheezing and you put the patient on end-tidal CO2 and you see an obstructive pattern, we're thinking that it's bronchoconstriction or bronchospasm. Basically, we would manage that patient like we would for any other bronchoconstricted patient. Bronchodilators, so we're thinking about giving them albuterol is probably the one that we're going to be most familiar with and what most of us carry, 2.5 milligrams. Ipratropium. Ipratropium actually, so let me back up. Albuterol is a beta agonist, a beta 2. So it dilates out the bronchial tree, which will help to alleviate some of that bronchoconstriction. Ipratropium, on the other hand, is actually an anticholinergic medication. So what anticholinergics do is dry secretion. So if this patient is a COPDer, but they have chronic bronchitis, it'll help to dry up some of those secretions, allowing for better gas exchange and respiratory effort for the patient. And then ultimately, depending on how severe this patient is, we may be down to administration of epinephrine. And we know that epinephrine is, in this situation, it's going to give beta effects. Beta 2 is what we're looking for. So it's going to open up those airways kind of like albuterol does, but through a different mechanism. So this will show you that waveform with an obstruction, and just kind of notice the shark fin appearance or how much longer it is taking for the waveform to take place. And notice inhalation. Inhalation is not a problem. It drops straight off to the respiratory baseline. So there's your shark fin appearance. All right, so return of spontaneous circulation. You guys are doing CPR and all of a sudden you note a sudden spike in that waveform. So I wanted to kind of make this arrow here to where you could see through it. It's transparent. So here's your underlying waveform of 10-ish of end-tidal CO2. And then suddenly you see that number shoot up to 30. I say this in live classes all the time and people laugh. You didn't just get better at CPR, right? There is a reason, a physiological reason for that occurring. And really the explanation is that the patient regained a pulse. So if you're doing CPR, it's 10, and all of a sudden you have a sudden increase, stop doing what you're doing, or keep doing what you're doing, I should say, and check for a pulse. You may have to stop to do a pulse check, but the patient probably has regained a pulse, and then you're going to follow your guidelines via HA and your standard protocol. This is ROSC being obtained. So we notice our CO2 is 11 currently. And now all of a sudden it went to 38. So again, at this particular point, you know, put a stethoscope on their chest, listen to see if you hear heart tones, and not necessarily like S1 or S2, but just do they have a change? Do they have a pulse that corresponds with that? Because that's obviously going to change our treatment. Now we need to hang antiarrhythmics to keep them from going back into whatever they were. A rising base